Hello, good day. My name is Juliet Ikejuba, and today, or right now, I'm going to be presenting my storytelling and spirituality creative assignment. This course is Nursing Science by Dr. Mayer. I will start with that I'm going to be starting with a introduction of story theory. Story theory, which Patricia Lear and Mary Jane Smith developed, was first published in 1999 and it has continued to be used, tested, and shaped for more than a decade. So it's over a decade that story theory has been in existence. Story theory describes a narrative happening that occurs through intentional nurse person dialogue. Remembering that the nurse and the person are two of the four components of the nursing meta paradigm that play a key role in storytelling theory. Explaining the two components of meta paradigm as related to story theory, the nurse as a care provider engages in therapeutic communication with the patients, initiating storytelling. So the nurse listens with full attention to the patients. The person, on the other hand, is the patient. And the patient responds to this communication or to this care provided by the nurse and feel relaxed enough to share their thoughts or their stories. Storytelling would bring about connection between the nurse and the patient. Example, during admission or when you're doing your nursing admission, the first time you come in contact with your new admits, you are setting a stage for a great communication for storytelling. It all depends on how you communicate with your patient. That would determine if the patient feels comfortable enough and trusts you enough with their stories, because not all patients would want to tell you some parts of the stories that are actually very important to their care. So your approach matters a lot. The next is going to be stories as an important part of nursing. I would agree with the fact that stories are an essential part of the nursing practice. Nightingale implored nurses to stop chattering and begin listening. For Nightingale, unnecessary chatter was a distraction for nurses, but listening, on the other hand, would allow nurses to understand the patient as a whole person and provide care that is comprehensive, individualized, and therapeutic. So, story being an integral part of nursing is going to help facilitate better communication between the nurse and the patient, and this will foster an environment where the patient will feel heard and validated, improving the patient's health outcome and the patient's satisfaction. Stories will empowers patients by involving them in their care. So when you involve in story during patient care, it makes the patient feel empowered that they are involved in their care, and it's going to make them comfortable or relaxed enough to share more with you, because you're not jumping to conclusion, you're not assuming, you want to hear from them. Even if they already gave information to whoever they saw first on their first interference in the hospital, whoever they interfered with, or not interfere, who they came in contact with in the first, immediately they got into the hospital, even if they've given the person the same information, you asking them again, it's like you wanting to be sure what you heard, what they said was true, or what was written in the paper or in their file is real. Sometimes you get like information that is contradicting to what you got on the papers, because when they first came in, whoever they interacted with had gotten like history, and those, maybe they might say that as a result of pain or feeling angry or whatever they feel at that time, but after little treatment from the emergency room, they might be calmer, and then they give you like better information. So I think story is an integral part, because you get more informations. I have seen many times contradicting informations from what was on the chart and what I was told by the patient. So it is an integral part. Stories will help you build trust between you and the patients. It's going to reduce patient anxiety. It's going to help them identify their real needs, and it's going to improve your assessments and the assessment accuracy, and strengthens the patient-nurse relationship. You want to always involve story in nursing. That is a very integral part. So the next slide is going to be on one assumption from Lear and Smith's story theory. So the assumption that I want to talk about is the assumption that people change as they interact with their world in a vast array of flowing, interconnected dimensions. So this assumption proposes that individuals are not static beings. Instead, they face continuous change through their interactions with various environments, which would include the social environment, the cultural environment, the emotional, and also the physical environment. When an individual engages with the world, like we as humans are not static. Our parents brought us to the world. We grew from infanthood to toddlerhood and to preteen, teen, and adulthood. And that is growth. So we are not static. We grow, we move. During each stage of our lives as humans, we come in contact with different things. Say, for example, from our families, while we grow, we learn our family values, we learn our norms, we learn the culture of our family. We also have a community where we come from, or a community where we live, and this community has their own custom and norms. So we interact with the community, we gain some changes by interacting with the community. As we go further in life, we go to colleges far from home. We also adapt and learn new. We gain new development from wherever we come in contact with. So in life, we are not static. We either gain positive change or negative change. It all depends on what we want to gain at that moment. But yes, it is true that we humans, we change as we interact with the world. So this is true. One concept that Lear and Smith story theory that I want to talk about is the intentional dialogue. So the intentional dialogue requires the nurse to abandon pre-existing assumption, respect the storyteller as the expert, and ask questions to clarify meaning. We don't know it all. Intentional dialogue is the central activity between the nurse and the person that brings the story to life. It is the act of querying the emergence of a health challenge story in actual presence. So what this means is if a patient comes to you with a health condition, that's your patient. You have seen such condition before. Let's use, for example, atrial fibrillation. As a nurse, you must have seen a lot of patients coming with atrial fibrillation, and you know a lot about atrial fibrillation. But this concept is telling us at that point, we should push away all our assumptions on what we think would matter most to the patient. So if the palpitation is what matters most to patient A, which you handled last week, that has the same atrial fibrillation, patient B that you're handling right now might not be super, let's say, might not be, it might not matter most to them. The palpitations might not be what matter most to patient B. So don't bring the assumption from your previous patients into the new one. That is why there is room for storytelling. You have to ask, you have to communicate with your patient, you have to get information from them, and don't just jump into conclusion that this is what matters most to the patient because it's atrial fibrillation. So I know this is what matters most. No. So this concept is telling us we should keep our assumptions and communicate with the patients to know what exactly matters most to them. Next slide, we are going to be talking about the barriers to learning. The first thing I want to talk about is my current work environment. So I currently work in a forensic psychiatric facility. It's located in Norwalk. It's Metropolitan State Hospital. I didn't put the name down there, but Metropolitan State Hospital located in Norwalk. In this facility, we provide specialized mental health care for individuals who are mentally incompetent to stand trial. So they are majorly the forensic population in mental health. So these individuals, they have psychiatric orders, and when the court sends them to us, it's our mission to assess them. The doctors would diagnose and will start treatment, and our aim is to make them competent to stand their trials. The facility has a structured daily schedule to provide patients with predictability and routine, including therapeutic activities, social skills development, and recreational opportunities, which are all essentials for rehabilitation. So our day-to-day activities is like pre-planned. There's like a timetable of everything we are supposed to do with the patient every day, because this is the plan that with years they have come up with this plan to help make the patient competent or bring them to competency enough to go stand their trials. It's not like we don't add different care or different plan in between, or we don't introduce new things to them. We do introduce new things, but majority of what we do is already pre-planned. It's like we already have a timetable of what we do. So this gives you an idea of the population that I work with. So the forensic psychiatric patients, they are actually very, very important patients to care for. Also, they are very important patients to care for. A lot of them with different stories. You read their stories and then you talk to them. Most of them have really touching stories, but like I said, our mission is just to make them competent enough to go stand their trials. And then in the slide, I would be talking about using story theory in my day-to-day nursing practice. In my day-to-day nursing practice, working with the vulnerable population, I incorporate story theory as an approach to meet my patients' needs and enhance the quality of nursing care that I provide. I strive to listen effectively to my patients during daily team meetings and monthly interviews. Like I said in the previous slide, we have daily routines that are already planned or set up just so we attain our aim of making these patients competent to stand trial. During those monthly interviews or team meetings, this is where we come and ask questions again to the patient to get updates on how they are feeling or how they are faring or how much they have how well they have gotten since the last time, or not how well, but what's the change, what's the difference from the last time we had an interview with them. I think that's a better word to use. Effective listening is critical aspect of providing compassionate care and fostering a supportive environment. With my patients, I try to communicate with them by asking them open-ended questions, because open-ended questions would help me get more information. It gives them space to express themselves more. Open-ended questions is like you're making room for anything. Just tell me whatever you want to say. I am listening to you. I am listening to you. So that's how you want to communicate with them. You want to use open-ended question. Another thing I do is I listen attentively without interrupting the patient while they are talking. You don't want to interrupt them, because interrupting them might kill the trust or it might make them feel demotivated to talk to you because they will feel you're not listening to them. So that you don't want to do also. Listening to the patient is a key part of compassionate care because it helps me build trust and understanding with the patient. Not help me, it helps the patients build trust with me, and it also helps build understanding between the patients and myself. Most of my patients would always come at random time to me because they know I would always listen to them and treat them with respect. Respect is one thing that you don't want to take away from this population of patients. You don't want to take respect from them. They are still humans, so you want to give them the respect that they deserve. With the psychiatric patients, I've had a patient that storytelling really helped, or prevents physical altercation with other people. Because this patient, during interview with him, or during the storytelling section with him, I had asked him what makes him, what do I look out for when he's agitated? And he told me that when he's agitated, he loves to hit. And that is not what we want. We don't want anyone hitting anyone. So I asked him what can calm him down, or what can we do calm down the agitation. And he said one thing that helps him a lot is music. So I had offered him a radio, to come get a radio from the nursing station whenever he feels agitated. Just come straight to the nursing station. And believe me, he would come to the nursing station like once in every 4 to 5 days to get that radio. So that was how often he gets agitated. And seeing his face, you can tell from his countenance that he's agitated. So we just give him the radio because I had to communicate with my peers and let them know that, not my peers, my co-workers, our colleagues, and let them know that this is what he said. So with this approach, we did not let it get his agitation cause an altercation between him and other patients. So we de-escalated the problem before it even started. So that is what storytelling can do in caring for our patients. So that is how I incorporate story theories in my day-to-day activities, and it helps a lot. When caring for the psychiatric populations, there are some potential barriers that can make it challenging for us to listen to the stories of the patient fully. The patients, when they come in, they present with symptoms that can make it difficult to follow their narratives. They come in with symptoms like disorganized speech, thought blocks, hallucination, paranoia, and anxiety. Take, for example, the disorganized speech. When you're talking to a patient and they keep going from one sentence, their thoughts keep going from topics to topics. So they don't continue a sentence on a particular topic. They hop from topics to topics, and this diversion of topics it's gonna make it difficult for the nurse to identify the main message the patient is trying to pass. The patient is going to mix up like unrelated content with important details, and the narrative becomes really confusing. Also with thought block, sometimes I'm talking to a patient and mid-sentence the patient just stops talking, and at that point I just know that his thoughts has disappeared. Like it's either they just remain mute or they divert to a random topic or something random not related to what you're actually talking about. Thought block at this point, thought block causes the story to be interrupted, and you don't understand the experience the patient is trying to share with you, and that becomes also impossible for you to understand the information being passed. A hallucination also can cause a barrier to listening, because I have been having conversation with the patient, and we were having a conversation and we were talking, and all of a sudden he just diverted and like, and when we're talking, he just said, oh yeah, I talked to my wife through the telephone on the ceiling, and there is no telephone on the ceiling in the hospital. I knew he doesn't call his wife on the telephone because they have a paid phone. I just know he's hallucinating because he said in his room that he talks to his wife, and there's something is going to be there for them to make them start hallucinating. In the room, there is like a little vent on the wall, and that's where he points at as a telephone. So probably he hears voices come out from the vent, and he says it's his wife's voice, but we know there is no voice from the vent. It's just him hallucinating. And at that point, during the conversation, and he brought that up, that actually changes the whole topic. The patient starts diverting and starts talking about what his hallucinations, and he loses reality. He loses touch with reality and goes back to hallucinations. I've also had a patient who was responding to internal stimuli while we were talking, and when I asked who he was talking to, he said he was talking to his little friend. And I'm like, oh, what is your little friend telling you? He said, my little friend said I should stop. I shouldn't answer you anymore. And that was it. He stopped answering me. He stopped answering me. So that's how that can be also a potential barrier. Hallucination can be a potential barrier because the voices tell them what to do and they listen to the voice actually. And then I will be going into shalom and spiritual health. So there are the two components of shalom that I'll be talking about is wholeness and peace. So wholeness. Shalom is a comprehensive concept that expresses society as God intended it to be, including a sense of wholeness, harmony, justice, and joy. This was gotten from Glenn M. and Watson, 2020. Wholeness refers to a state in which all dimension includes the person's physical, emotional, mental, spiritual, and relational, are integrated and functioning in harmony. Wholeness as a component of shalom can be applied to nursing care for a patient by understanding it involves providing care that addresses not only the patient's physical but the patient's emotional, social, spiritual being also, because it's wholeness means caring for the patient as a whole person. You're not just caring for their illness, you're caring for their emotions, for their spiritual needs. Like as a nurse, I create therapeutic atmosphere for my patient where I can offer compassion, I offer respect and dignity that will support patients' overall well-being. Showing respect to the patient's choices and their preferences also while caring for them. I ask the patient sometimes if they need a religious preference, because we have patients come in and they want to see the priest, they want to see the pastors, they want to see the imam for the Muslims. Yeah, they just want something. They want they have a religious preference, and we offer such visits from the religious leaders to come see them. And sometimes they do lead to religious gathering for them where they come take all the patients of a certain religion to the gathering, but it's still within the facility, which is highly secured. So these religious preferences, when you offer them to the patients during their hospitalization, it helps also in caring for them. It provides a very supportive atmosphere for them, because at this point they feel they really care for me because they're caring for my spiritual needs. So that's shalom. Shalom means wholeness. It means caring for the person as a whole person. And the next component of shalom I'll be talking about is the peace. So peace is like a general component. It's like what everyone think shalom is. Shalom, peace. That's how I know shalom. When I hear shalom, I say shalom, peace. So shalom not only focuses on vertical relationship between God and us, but also includes the horizontal relationship between human beings. In caring for my patients, Peace can mean fostering an environment conducive to aiding the patient's healing and their well-being. As a nurse, I create a relationship between myself and the patient by listening and by constant communication with them. I make them feel free and relaxed while communicating. I try to understand their emotional states and address any fear and anxiety that they may have, because understanding that they have fear and anxiety brings them to peace, because they've seen someone understand that they are not perfect and they have fears and they have anxieties, and you are there for them to foster for their needs, to care for them. We need not fear anything, because God's perfect love casts out fear. That is from Tesla 2021. It's from one of the articles that we read. That part is the part where you bring it into the patient's life. You want to foster a care that would drive away fear. You don't want the patients to be scared. So Shalom means creating a space where there is peace, so the patient is not anxious or has no fear at the moment. So when you're creating a peaceful interaction using your empathic communication to make the patient feel heard and validated. Peaceful communication will also foster trust and reduce fear. Like that's what I just explained earlier. And then the next one, there are two questions. One of the questions I'm going to be asking the patient from the FICA tool would be the question of what gives your life meaning. So this question, when you ask this question, the patient will be engaged in reflecting on their core values, on their beliefs, and what they prioritize in life. Different things can mean different things can give meaning to people's life. It can be their spiritual beliefs, it can be their family, it can be relationship, career, or even their personal achievements. We don't assume what would give the patient meaning. Asking them would tell us what gives their life a meaning. When we understand what matters most to a person, we are gaining an insight into their spiritual and emotional health. So engaging in this discussion would help you in acknowledging acknowledging the person as a whole person, which will reinforce the person's dignity and their worth. So it's going to show that they actually want something or mean something, because you want to know what gives their life meaning. And when they think about the question, it's giving them room to reflect on what actually means, what means or what matters most to them. So this question makes you understand or make you get what matters most to them, to the patient. And when you know what matters most to your patient, it gives room to channel your plan of care towards meeting the patient's needs or whatever means a lot to them. So you want to channel your care to that, or your plan of care to what matters most to the patient, because you don't want to neglect that part. Neglecting that part will make them feel worthless. So this is why you should ask the patient what matters most, what gives their life meaning. The next question I want to ask is, are you part of a spiritual community? Asking a patient if they are part of a spiritual community it will help understand the patient's spiritual life and how it may influence their health and well-being, because asking this question will allow the patient to express the importance of their spiritual community, their influence, and the role it plays during their health care. So knowing whether a patient belongs to a spiritual community helps you tailor or align with the patient's belief and values, because You don't want to disrespect a patient's belief. You don't want to disrespect their values. As a nurse or a healthcare provider, you want to respect your patient's belief and value. This question will further to make you ask further when they tell you what part of if they are part of a spiritual community. It's you can go further and ask the patients if they want the involvement of the community members or the leader in their care, because I've seen patients who would request that or who accepted a visit from a spiritual leader or their members of the spiritual groups to come see them, because the presence of them, their presence in the care of the patient it's kind of influence the patient. It brings supports to them in like social supports to the patient, and it provides them with companionship and encourages or brings a sense of belonging to the patients, because they're going through a lot and they need the involvement of as many that they can get, or as much support as they can get from the community that matters most to them. And asking this question would make you know if the patient wants you to involve that community into the care. As a nurse, you want to ensure that the spiritual care of the patient is integrated to the patient's plan of care as long as the patient says yes. So always engage it. It really helps a lot in the patient's care. And next up, the biblical perspective. From the Bible verses that was given to us, I had picked two themes from the scriptures on how I use the themes to care for my patients. Using Ephesians 4:1-7, I picked out from Ephesians. Ephesians emphasizes, that Bible verse emphasizes unity. It emphasizes gentleness, patience, and humility. And all of this can be incorporated into your patient care by showing humility during the care of the patient. You want to be humble when you are approaching each patient. You want to recognize that every patient has their unique experiences and perspectives. So you want to be open to listening to their concerns and their feelings. When they have questions or concerns, you want to give answers to the best of your knowledge. You want to be sincere with the answers and admit when you don't have the exact answer they need. You want to let them know that you don't have the exact answers, and you would go get more information and come feed them whatever information you must have gotten. So you want to care for your patients. You want to be humble when caring for them. You want to be gentle with them. You want to be genuine. You want to be real. You want to be patient with them, because sometimes their health condition can make them feel a certain way, and it takes patience to manage a patient. It takes patience to manage a patient. So you want to be patient with them, because it's not easy for them to be in the condition where they are. Nobody wants to be in the hospital. So I learned that early in my nursing career, that it takes patience to care for your patients, because you have to understand from where they are coming from. I don't want to be in the hospital, so everything might be irritating to me, and I did not wish to be diagnosed with this. And we are there to care. So I put myself in that shoes, and I understand from where they are coming from, and I become super patient with them no matter how they react. But patience would bring your patient peace sometimes, because when they notice you were so patient and you were so calm with them and gentle, it's automatically changes their perspective, and it calms them down, and then they start listening to you and understand every education that you try to provide to them. Another Bible verse that I incorporate into my patient care is Psalm 37, 3 to 6. So Psalm 37 encourages us to trust in the Lord, do good, and enjoy the blessings of the land. It emphasizes faith and righteousness. By doing good, you want to provide compassionate care for your patients. So compassionate care is providing the care that will go beyond clinical aspects, such as offering the patient emotional support. You want to offer them comfort. You want to be an understanding nurse to them, because, like I said in the previous slide, nobody wants to be diagnosed with such medical condition, or they have other things they're doing that this illness is taking their time and it's not making them move forward the way they want to. So you want to show your patient compassionate care. You want to be nice to them. You want to understand from where they are coming from, because that is one thing that separates a nurse from every other person. Compassionate care. You need to show compassionate care as a nurse. It separates us all the time from every other person. So that is one verse that I incorporate in my care, in my patient's care. You were talking. Okay, so I will be talking about how the scripture verses relate to the idea of listening to a person's story. The first one I will be discussing about is active engagement. A part of Jeremiah 29 that says, "Then you will call on me, and I will listen to you." That part, God promises to listen to us, and which he actually does. When we call on God, most times he listens to us. We're calling on him is telling him our problems, telling him what we want, telling him how we want things to go. Sometimes it doesn't always go the way we plan, but it goes the way he wants it to happen. And at the end of the day, God's plan is always the best, but he always listens to us. So what this is saying is that we as humans, or we as care provider, me as a care provider, or as a nurse, I should be an effective listener. I should listen to my patients. I should practice active listening. I should active listening. It involves not just hearing the word, but also understanding the emotions and the context behind them. Like when we call on God, when we ask for something, we ask with different emotions. Sometimes you're happy, sometimes you're sad, sometimes you're crying. That is the same way you need to understand the emotions in which your patient interacts with you. So you have to listen. You have to be attentive when engaging with the storyteller. This will make them share more freely, because they see you as someone who is listening to them and you understand what they are saying, and it's going to make you have a deeper connection with the patients. This is really one of the important part of storytelling. I would say active listening is very important. So the next one I'll talk about is gentleness. Ephesians 4, I would read, it says, always be humble and gentle. Be patient with each other, making allowances for each other's faults because of your love. When you're approaching each person or each of your patients, you want to approach them with respect and sensitivity, because it's going to help you. It's going to help in acknowledging the dignity and the value of the storyteller. Because the storyteller, when you want to approach them, you have to be gentle with them. You have to be humble. You have to show them that you're not there to judge them. You have to show them that you're not mad at them for what they're about to tell you, or you have to make them know that they are not taking your time. You have to be really gentle and humble with them. If you don't have time to discuss with them at that time, you can come back and tell them, oh, please give me 5 minutes. Let me come back so I can have full attention. You need to be humble. If you don't have a solution to your problem, you just you help them get a solution to the problem. If you don't have it at that point, you want to advocate to make for solution. You want to work with these patients. You want to be in unity. When you're in unity with the patient, you guys are having a good collaboration. Storytelling is going to be smooth. You're going to get a lot of information. You're going to impact more on the patient, and your plan of care for that patient is going to always include whatever you have gotten, whatever information you got from the patient that means, or it's of high needs for the patient at that time. So this part of the scripture also relates to listening to a person's story. And then the third one I want to be talking about is trust. Commit everything you do to the Lord. Trust Him and He'll help you. This was from Psalm 37. Effective listening requires a foundation of trust. You have built trust in God. You call on God, you talk to Him, you tell Him what your problem is. Look, God, please, this is my problem. And then you trust that He's got the solution. And then you stop worrying. You stop being anxious. That's the same way you need to build a foundation of trust with your patient. You need to build trust by giving your patient full attention. You need to communicate with them in a way that they are valued and safe in your care. You want them to trust you enough to tell you their problems, and hoping or believing you would have a solution, or you would work to get a solution. I know it's not always easy to get solutions to every problem, but building a sense of trust and making efforts to get solution, it's going to make your connection with the patient deeper. It's going to build the trust with the patient. So this part is one part that I also use, which also relates to the idea of listening, because God listens to us and we trust Him. So we listen to our patients, and our patient trust that we would help them with their pressing needs, or what matters most to them. And that would bring an end to my presentation. And here I have 5 references from textbooks and from the journals that I got. Thank you very much, and I will be signing out now. Thank you.